Let me just bring you for the path of HIV journey. Starting from the discovery of the AIDS cases, and then 2 years later, we discovered the virus. And with the virus, we can do many more, like a diagnostic test. We studied pathogenesis, and then the treatment by developing the ARV. On the left-hand side, on the yellow one, is the response of various parties on this response, which I will come back later on. So AIDS was first described by Michael Gottlieb about 30 years ago in June 1981. 2 years later, Luc Montagnier and François Barré-Sinoussi discovered the virus in 1983, followed by Robert Gallo a year later. And then once we have the virus, we have the diseases, and we can study the pathogenesis, as we have heard from the first speaker, the CD4 cell receptors, co-receptors. Don't forget about Anthony Fauci, my good friend there. Then the journey of HIV treatment. Let's start with journey of HIV treatment. We start from no treatment to then monotherapy, and then dual therapy and triple therapy. We started from first line, now we have third line, fourth line, whatever. We also started from salvage therapy, i.e. to keep the people healthy rather than to aim for viral suppression. Now we have viral suppressions. We start from complex therapy to simplified therapy, from limited access now to universal access, from treatment alone now to treatment as a prevention, and also from untreatable diseases now to treatable and possible cure in the future. When to start ARV is a pendulum. It swings back and forth. From the first availability of ACT back in 1986-87. So the drug was used to treat those various sick people, treated late. In 1996-1998, we know about HEART, the combined antiretroviral therapy, with the possibility of to cure. So at that time, 1998, many people talk about cure, earlier treatment. And then several years later, we know that it cannot be cured. And the treatment itself may cause certain side effects, so people have some more reservations to start it somewhat later. And in 2008, we know that if we start late, we have many other problems like diabetes, coronary artery diseases, and so on. So we then started earlier in 2008. With the announcement of treatment as prevention, HPTN 05T, we then expect that probably in the future, we'll even start treatment earlier. So my prediction is it will never get back again for the late treatment. We all know about the risk benefit of early treatment. The only risk of early treatment is cost. You can mention it with anything, but cost is the main problem. But the benefit of earlier treatment are varies. For example, preventing OI, preventing diabetes, preventing myocardial infarction, and so on and so forth, as well as preventing the HIV transmission, to me, which is the most important gain or benefit of earlier treatment. As you can see in this slide here, in the recommendation in the US, for example, for people who are asymptomatic, CD4 around 200 to 350, 2008, this is the first time that they recommend treatment of people with CD4 less than 350. And in 1 year later, now US recommendations is to treat everyone with CD4 less than 500. Look at our developing countryside. Okay, WHO guidelines, just only 2009 that recommend we need to treat people with less than 350. I would predict that in the future, with the treatment as prevention, the WHO may want to change the guidelines that probably lower than 500. We may need to start treatment now. So these are the drugs available for as treatment. As we have heard, we have RT inhibitors, protease inhibitors, entry inhibitors, and integrase inhibitors. These are all the drugs and drug combinations that is available in the US as well as in many countries, including in Thailand. In every year, we have about 1 or 2 new drugs developed. Just this year alone, 4 new drugs have been approved for use. Ribavirin, extended release of Viramoon, and Compila, the combinations of ribavirin, tenofovir, and FTC. At the same time, there are many drugs are being on the phase 3 trials this year. That means more and more ARV will become available. And as you can see, more and more of them will be more expensive. This to compare which drugs to be used between the developed countries, the yellow one, and the developing countries, the green one. Just look at what is going on now here. The drugs being recommended as a first line in developing countries is more or less a little bit a step behind those being used in the rich country. For example, right now, in the rich country, they no longer, at least in the US guideline, they don't recommend ACT3TC anymore. But in our developing world, we still use ACT3TC. The same thing here. In the developed world, they no longer recommend nevirapine, but we know that nevirapine is cheap, we still use it, nevirapine or efavirenz. The same way for PI. PI, lopinavir is the only PI available in our region here. But in rich countries, they have many others, atazanavir, darunavir. At the same time, for integrase inhibitor, is also available as a first line in the rich country. When you look at the second line or third line, in the rich world, they will test it or select which drug to be used based on resistance testing. But in our developing world, there was a recommendation that we use tenofovir, 3TC or FTC, and lopinavir. And also, if we resist the second line, we have the third line, ralticavir and darunavir. At least second line and third line drugs have been mentioned and listed. However, in many countries, especially the third line drug is still not yet available in the developing countries. Treatment of HIV infection is just not ARV itself. We need to treat HIV and ARV-related complications, like metabolic complications, premature aging. We have heard that immune activation and also inflammation play a role in HIV diseases, play a role in many HIV-related morbidities. So there are several attempts nowadays, as we have heard from Professor Lee, activation inhibitor, inflammation inhibitor, immunosuppressive, and antimitotic drugs, for example. And mostly, we also hope for HIV cure. When we look at the journey of universal access, which is a long journey, about 11 years now, starting from 2000, where we had a meeting in Durban, they called for access to all. And then a year later, UN declaration, and then the availability of Global Fund, PEPFAR, and also the intention of WHO and UNAIDS of 3 million being treated by the year of 2005, which was achieved in 2007. 3 million people were treated in 2007. And then we have a new WHO guideline for earlier treatment. We have 6.6 million people being treated on the year 2010. And then just this year, we all heard about the exciting story of prevention as treatment on HPT, and which I will touch a little bit later on. So right now, treatment is prevention. HIV treatment and care in Asia, in overview. Asia as a whole, probably we think we're better in terms of healthcare infrastructure, better in terms of financial things here than Africa. Almost all ARV drugs are being produced, even the raw materials are being produced in Asia. However, the number of people in Asia are being treated is as low as or as much as in Africa, 31% compared to 37%. Even in our region, we have much lower number of absolute number of people to be treated. Why? Why Asian cannot treat more than 31% of HIV infected persons who are in need? In fact, the number of people treated has been increased 4 times now since 2005 to 2009. But only 3 countries where they can achieve the so-called universal access by the time of 80% of being treated, Thailand, Cambodia, and Papua New Guinea. However, PMCTC coverage in Asia is much lower than Africa. We can achieve only about 32%, whereas in Africa, 54%. At the same time, many countries in Asia, also in Africa, all the treatment depend on external funds, except Thailand, China. We have to, and India. We have to depend more on ourselves here. What are the challenges of HIV treatment in Asia Pacific? Wider access, universal access, earlier access to care. But in terms of earlier treatment, that means you have to diagnose the patients earlier, and also get a shorter time from the time of diagnosis to be on the care procedures rather than to lost during the time of getting CD4 and making clinic appointment. Cost is also a very important issue. Manpower shortage is also a very important issue. Don't forget about those long-term follow-up of HIV infected person, where now they will live as long as non-infected people. For me, policy commitment to commit that treatment is a prevention. Not treatment is a separate thing here. So there's no money for prevention. Treatment itself can be a good way for prevention, so that the government or the country can give you more budget on the treatment side, which is also good for prevention. Adherence. The other thing here is, I think also very important in Asia, homophobia. Okay, once we have homophobia, it will be very difficult